Hello, this is Rebecca, and I'm going to go over the second half of chapter 46 from your Understanding Medical Surgical Nursing, continuing with musculoskeletal and connective tissue disorders. I think I am going to share my screen. Now, I'm showing it as a Menti this morning because that's just how I had it set up to do in class. You're not going to be able to do this Menti from home, but when it comes to the questions and times like that, then I'll have you just go ahead and kind of answer how you would normally in the class. All right, so we have Understanding Medical Surgical Nursing. Our learning outcomes are to talk about osteoarthritis versus rheumatoid arthritis, assisting in planning and nursing care for the patient with a fractured hip, planning care for patient having a total joint replacement, and explaining teaching for patient with lower extremity amputation and prosthesis. So let's talk about osteoarthritis. We talked about rheumatoid arthritis in class. So we're going to compare and contrast a little bit here. Rheumatoid arthritis is more of that autoimmune disease. And so you're going to see like your body's response to those factors. You'll see the irritation, inflammation, and pain. You might also see some slight fever and other things that would be associated with an immune-mediated response, where the osteoarthritis is more of a degenerative joint disease, and it usually gets worse with age, while rheumatoid arthritis is something that's more, it can usually begins in childhood when that immune system kind of attacks those joints. So the pathophysiology, it does attack, the arthritis attacks the entire joint. It might be in certain joints though, right? People might have maybe joints in their hands more affected than the joints in their legs. It kind of depends person to person. The joints and cartilage ends begin to deteriorate. Because of that deterioration, that joint space kind of narrows in a little bit. Sometimes they can even develop some spurs, bone spurs that are pretty sharp and painful. It ends up having the patient will experience a lot of pain. Because of that pain, they have some immobility. They're not going to move it as much. Especially this is concerning when we talk about our weight-bearing joints, because then the patients aren't as mobile, which leads them to a lot more complications. So these are all the joints that are affected by osteoarthritis, or OA. Sometimes we abbreviate it. And you can see how all through our body, there are joints that are affected. So some of the risk factors, why would people be more likely to have it? Well, hereditary. If your parents have it, you're more likely to have it. As you age, you're more likely to experience arthritis. Obesity, that can also be another factor. And then also excessive wear and tear. Again, I think about our athletes, people who are professional athletes or just had a long history of athleticism, or even careers like a carpenter or somebody who uses those joints a lot more. The more wear and tear, the more it's going to eventually break down or has potential to break down. So what are the signs and symptoms? Well, pain, that's one of the first ones. It usually will intensify after physical activity, which if we're kind of comparing and contrasting rheumatoid arthritis, usually people start with rheumatoid arthritis having more pain, and then as they have activity and kind of warm up the body, that pain decreases. Osteoarthritis, it usually their pain intensifies with activity. Osteoarthritis, they're going to have stiffness, and they can also develop these bony nodules on their joints and fingers. So how do we diagnose it? Well, x-rays, MRIs, those are really helpful to kind of look at the structure of the bones. They also might do an aspiration of the synovial fluid and kind of analyze that. So what do we do for these patients? There's no cure, so we're not going to be able to take it away, but we can do some things that can help. Things like exercising, having more stronger muscles and joints, or the supporting structures can help to stabilize joints and make them stronger. Weight control. If you have more weight pressing in on those joints, making it harder to work, that can be pretty painful. That can help. We might give them some NSAIDs. or other medications that can help with the pain. Sometimes heat or cold therapy can be helpful. We might also talk about complementary therapies, and we're going to talk more about those when we talk about pain in a couple weeks. But we want to make sure we're not just relying on medication. We're also using a holistic approach. Eventually, some of these patients are going to need to have surgery, especially if it affects those major joints like the shoulders, hips, or knees. So our nursing diagnoses associated with osteoarthritis can be acute pain, activity intolerance, chronic sorrow, disturbed body image, impaired physical mobility, or sometimes even a self-care deficit. They're not able to move around like they normally would. Our education is going to be focusing on protecting their joints and also conserving energy because they're going to maybe not do all that they wanted to. Okay, so now we're going to flip over and talk more about rheumatoid arthritis. Now, this is a chronic, progressive, systemic inflammatory disease. It destroys the synovial joints and other connective tissues. It can also affect other major organs. And like I said before, this is an autoimmune disorder where the body is attacking itself. You can kind of see, here's a finger joint, and you've got this inflammation and then this swelling that occurs around the joints themselves. That synovitis, or the inflammation of that fluid, and the synovium thickens as that fluid accumulates. It destroys the cartilage, the bone. Anyway, you end up with this deformity where a lot of times they see it. You might see it in patients' hands, where they have these large overgrown joints that just look very odd because of that. Here we go. Here's a picture where it kind of shows these enlarged knuckles and joints from the rheumatoid arthritis. I remember I went to high school with a young man who had rheumatoid arthritis, and he was a junior in high school, so probably around 17, and his hands were just grossly swollen with these huge knuckles. I remember him saying how much they just hurt, and I can't imagine. That must have been really awful. So why do people get this? It's genetic. If it runs in your family, you are much more likely to give it. Occasionally, there might be an oral pathogen that can cause the systemic response to stimulate this autoimmune response. So you're going to have local inflammation, like at the joints, but you might also, like I said earlier, have a systemic response where, because of that inflammation and the autoimmune response, you might have a low-grade fever, general body aches because of this immune response. So signs and symptoms, this is a little bit different than osteoarthritis, where osteoarthritis is progressive and it's going to get worse over time as you age. Rheumatoid arthritis is going to have times of remission and exacerbation. Remission being where it's controlled. The symptoms they might still be there to some degree, but they're not terrible. It's a tolerable life. And then you're going to have exacerbations where it really flares up and is pretty uncomfortable. And these are going to vary by individual, as well as time of year, the season that it is, stress factors, those types of things. Early symptoms are usually joint inflammation. You might see the joints getting red and stiff, especially after you've been resting. And so this is different than osteoarthritis, where osteoarthritis, that joint might feel better after you rest it, where rheumatoid arthritis, you rest it and you're like, oh my gosh, this hurts. I need to move and start getting up to kind of loosen things. Like I said, they might have the low-grade fever, weakness, fatigue, anorexia, not feeling like eating very much. Later, when you have this disease, the later symptoms, you're actually going to see this joint deformity, and they might even develop some osteoporosis as well. Some diagnostic tests we can do to actually diagnose these. We're going to look for a rheumatoid factor. That would be one of those genetic markers. Red blood cells, the C4, erythrocytes, you can see all of these. So what are we going to do for them? So medication, they might need an antibiotic. We might give some anti-rheumatic drugs. The Arava and Enbrel might go to methotrexate, NSAIDs, or prednisone to help decrease the swelling. It kind of depends on what state the patient's in. Some therapeutic interventions, we're really going to work on overall health to support this. So just health maintenance, getting good exercise, good sleep, weight control, good diet. We might also add in like heat and cold therapy. And eventually they might even need a joint replacement if they have that degree of immobility or joint deterioration from the arthritis. Some of the nursing diagnosis, fairly similar to the osteoarthritis, but they're going to have acute pain. They might have disturbed body image because of the deformity with the joints. Patient education, we want to talk to them about the disease process, medication management. I like that we put in vocational counselor especially because this can start with youth and with children or young adults. They might not be able to perform fine work with their hands because of those joint deformities. So they might need some help with finding careers that they don't need to have those fine motor skills with their hands. Okay, so moving on to hip replacements. So this is going to have information that's pretty helpful when you're thinking of all major joint replacements. And when I say major joint replacements, we're usually talking about our shoulders, hips, and knees. Those are our major joints that kind of take up the brunt of the wear and tear as we move through the body. So here in this slide, you can see there's this acetabular cup in the pelvic acetabulum. And then there's a femoral complement inserted into the femur. Super interesting. I always say that our orthopedic doctors are like the carpenters of the surgeons, because literally that's kind of what they have done here is they have probably either taken off part of this femur, or if anything, they have hammered in this huge piece to stabilize that femur and then to put it into this new joint here. The sounds that you will hear out of an operating room where there's joint surgeries, I mean, it is hammering, sawing. I mean, it's out of a horror movie, but they are working with these big bones and trying to stabilize or refurbish them. So it's pretty interesting. It's always nice to have these pictures. So when we talk about a total joint replacement, you really want to get them a lot of education beforehand, because there's a lot of risk factors and a lot of things we want people to remain healthy or to stay healthy after surgery. And if you wait until the day of surgery when they are all doped up in pain and had just come out of surgery, they are not going to remember much of that. And so you really want to, a lot of places have a total joint education program where they will even come to classes or see a nurse a few times before their surgery so they can go over all these things, their care that they want them to have after surgery, and then even to get them ready for surgery. Most places in preparation for an elective joint surgery, which means maybe you have arthritis that's worn and torn your hip, and you need a new hip, they will make sure that you have, like, your teeth are healthy, right? Because if you have a tooth that is infected, that infection can go into your bloodstream and eventually infect that hip. And we do not want that to happen. Infected joints are just a mess. And they have a lot of complications from infection, or there could be complications from infection. So one of the preoperative things is making sure people have a clean bill of health from their dentist before they're cleared for surgery. So there's a lot of things that go into preparing the patient for surgery. One thing we like to do before patients have surgery is that they'll have an antibiotic 1 hour prior or within 1 hour of incision care. Usually that's not a nursing responsibility because we don't always know exactly when the incision will happen. Usually anesthesia takes care of that, but as nurses, we also are going to be the process checkers and making sure that that is done, or that's, been ordered. It's part of that system. Some of the post-operative things we're going to check. So hip dislocation. This is not as common anymore. Most of our hips replacements used to be done anteriorly, which means the anterior, the front of the bodies, that's where the incision was. And when they did the hip replacements anteriorly, if you flexed your hip, like leaning forward, you could dislocate that new joint because of the weakened muscles from that incision. And they really were very cautious with how you moved patients and positioned them. So like, here's a picture where if somebody had a hip replacement that was an anterior hip replacement, the incision was at the front, you didn't want them to lean over 90%. So you had to really teach them some things how to not do that. Now in current practice, there's a lot of surgeons who have chosen to switch to posterior hip replacements, where the incision is actually kind of on the back part of the gluteal almost area in the bottom, or the side of the hip. And with those, you don't have those same type of precautions. You can lean and bend however they want. That being said, if you have an NCLEX question that's talking to you about hip precautions, and it doesn't specify if it was an anterior or posterior surgery, you're just going to assume they're talking about dislocation precautions and not have them flex, less than 90 degrees. Or greater than 90 degrees, excuse me. All right, so let's go back. So we also are looking at skin breakdown after surgery. These patients, especially with hips, similar with knees and elbows, but hips tend to be a little bit more immobile. We don't want there to be any pressure injury. So we're going to look at where they're lying. A lot of times in bed, we want to look at those spots, which, think about it. Where are they lying? Is it their shoulders, their bottom, their heels, things like that? And we also are going to be providing pain relief. So infection is another issue for any type of surgery. So we give them the prophylactic antibiotic before incision, but then a lot of times providers will order antibiotics for after surgery. And that's just to prevent anything that they might have been exposed to. They also, to prevent pneumonia, because patients are not going to be up and moving around, breathing like they should, they're going to teach them how to cough and deep breathe. Sometimes they'll use an incentive spirometer, and I believe you guys are going to be getting an incentive spirometer in fundamentals or foundations if you haven't already. That's a device that helps to expand your lungs. If your patient doesn't have one of those, you have them take a deep breath and then cough, clear those lungs. And that was a pretty big cough, right? That's what I want my patients to do. When I'm teaching them how to cough and deep breathe, I'll say, okay, now it's your turn. And they'll go, I said, okay, right now is not the time to be polite. Right now, I want you to show me that you can clear your lungs and help prevent pneumonia. So let's try it again. And so I have them take the deep breath and do that big breath with the cough. We also want our patients to look at their incisions. Anytime you have an incision, it's at risk of having an infection. So we're teaching them to look at those incisions every day to monitor for any type of infection, right? So look for redness, swelling, drainage, anything that might show infection. We're also looking for bleeding, especially in the first day, maybe two after surgery. We're looking at the incision, but then remember, how are they positioned? Because if they are bleeding around that area, it's going to follow gravity of where that blood might pool. So you might see that bruising, maybe if it's hip and they're laying flat, it might actually be more in the lower hip buttock area of where you're going to see that bruising. We also want to check neurovascular status. So if it was the right hip, I'm going to be looking at that right leg. Is it warm? Is it cool? Is it, I'm going to check the pulses. I'm going to check sensation, cap refill. And when I'm checking that with that right leg, I'm also checking it against the normal left leg, because I want to make sure I know what normal is for them. And I want to compare that surgical site to that. So how do we get them to prevent some of these complications? Well, I think ambulation is one of the best ways. We want them up and we want them moving. So especially with our total joints, they're going to have physical therapy and occupational therapy working with them, making sure they know, the proper ways to get up and move. We also are going to be teaching them to use a walker or a cane. Usually with the hips and knees, they'll start with a walker and then progress to a cane. With a shoulder surgery, usually they'll just have a cane if necessary, but they don't usually have the restricted mobility for the lower extremities like the total hip and joints, the hips and knees might have. Um, we really want to make sure every 2 hours they are up and moving. One of the big things I teach my patients when they're going home is to stay very well hydrated. I tell them to drink enough water to keep their urine clear. Because if it's clear and hopefully almost colorless, that means that at least every 2 hours, if not more, they're going to be getting up and going to the bathroom, which means they have to ambulate, which is going to increase their circulation and their blood flow, help prevent blood clots. It's also when you're standing upright and you're moving, you're taking deeper breaths. That helps to prevent pneumonia. And then they're just flushing out their system as well, which is super helpful. Um, thromboembolic prevention, so blood clot prevention. We talked about just exercise. We might have a compression device. You guys have some sequential compression devices in the foundations lab that if you haven't worked with yet, you will. They're little wraps that go around the legs, usually just the calves. They have air pockets in them that attach to a machine that gently inflates the air pockets and compresses and lets go. That just helps to keep blood flowing while the patient's your blood's going to flow, but it'll help keep the blood from pooling in the leg. That goes on during surgery or while the patient's in bed. We also have them do some exercises. We'll have them move around. Even if they're in bed, we'll have them do gas pedals with their feet. Push down, push up, raise up and down, just things to keep moving. And then we also might give them a preventative anticoagulant, something to help blood keep from clotting. Even like a low-dose aspirin, like 81 milligrams, can help with that. Here's a case study, so go ahead and pause this while you read it. You're preparing to give handoff. Think about the information and then turn to your neighbor, or if you're at home, just reflect to yourself using SBAR. And here is the suggestion of what we would suggest could be an appropriate SBAR response. So when talking about total hip replacements, especially, and all the joints that are replaced, self-care is an issue. They might need assistive devices or grooming devices. I think specifically, like with the leg surgeries, they might need like an extender to help them get socks on. With the total shoulders, they might need some help because they only have use of one arm. So a raised toilet seat is something that can be helpful, like in the bathroom, or even a shower grab bar to give them a little bit more security. With the knee replacements, you have can be femoral. There's lots of areas that can be worked on. You don't have an issue with dislocation, but the post-operative care is very similar to the hip surgery, kind of like we talked about. Amputation. So amputation can be either planned or traumatic. I guess we could say surgical or traumatic. Surgical amputation would be when you have either a bone infection or tumor or something that's happened where that bone is deteriorating and you're worried about it spreading, right? And so you want to remove that area. I think about our diabetic patients who have those infections that get into the bone, and then we have to take out that infection if it's failed antibiotic therapy. Traumatic amputations are more from accidents. So I think about, a traumatic limb amputation, like an arm or leg from some sort of accident, bomb, war. I also think about like our carpenters, having issues with saws, like maybe a finger getting amputated. So talking about finger amputations, replantation is possible. Replantation is when they take the affected limb and replant it on. Now, usually fingers or toes are what are replanted. We wouldn't necessarily be able to replant an arm or a leg. If this is the case, like if somebody has a traumatic amputation, you would wrap that severed body part. So actually this happened to my sister. She had her finger, just the top of it was smashed in a door frame, and it came off. And my mom was a nurse, and so she told my dad to go get a towel because you should wrap it in a clean, slightly moist cloth. I was 6 at the time, I think. And I remember my mom was like, go find your dad. Where did he go to get this towel? And I went to go find my dad, and he was over by the bathroom dry heaving because he was so like couldn't handle it. So I guess I was destined to become a nurse because I went and was like, well, I'll take the towel to her and I'm, I was going to help. Once you have that limb or the body part wrapped in a slightly moist towel, put it in a sealed plastic bag, and then put it in, sealed bag, and then submerge it in ice cold water. You're just doing that to try to preserve the function, any function that might be left. And then you're going to take that person to the hospital. So there's different levels of amputation, especially when we talk about our legs and our arms. BKA and AKA. I've had a lot of people get confused about this. B is below the knee. So below the knee amputation. AKA is above the knee. So if you don't know what they have, look at their leg. Do they have a knee? If they have a knee, that's a below the knee amputation. So similarly for the elbow, below the elbow or above the elbow. So some of our nursing diagnosis is going to be a knowledge deficit of just what is happening and what do we do? And then we also want to look at that disturbed body image. That's going to be a factor that will affect everybody after an amputation. So after the surgery, want to make sure we're watching for hemorrhage or bleeding. Infection could be a risk. Pain control. One thing that, especially with our traumatic amputations, patients can experience phantom pain or phantom sensation. And that's when, even though the limb is gone, it's removed, they still feel it. And it's usually a pain, a numbness, a tingling. It's something uncomfortable. We're also going to be teaching our patients about mobility because their mobility is going to be affected. They'll have to change how they do things. They might have a prosthesis. So if they have a below the knee amputation or an above the knee, they might have a prosthetic leg that is fitted for them and put on. All right, another IS bar. So go ahead and pause and read the communication. All right, go ahead and read kind of the instructions for this activity and then pause again. And we'll go ahead and practice your S-bar. And here is the suggested answer for the S-bar. Practice tip, we want to make sure that the LPN can have safe client handling techniques, provides care to an immobilized client, and reinforce client education. We're going to attend to mobility needs and assure that available and safe functioning of client care equipment. So here's a case study. Go ahead and read through this or pause while you read through this. She has a skin breakdown that started on her sacrum and hasn't had a bowel movement for 4 days. So go ahead and pause while you read through these questions. And this is a care map that we're looking at where Katie is in the middle and we're saying, what are her big issues? Well, we can say that mobility is a big issue for her, tissue integrity, elimination, and safety. From these issues, we can kind of put a little dot out to what's causing her mobility. Well, she had her hip repair, right? Tissue integrity, because she has this sacral breakdown. Safety, because she has a history of falls, and we know she also has difficulty ambulating. So this is an example care map just to start starting to get you thinking about care maps and how different diagnoses look and how they might relate to each other. Eventually, when you start some of your clinicals later this term, we're going to actually connect some of these. For instance, we know there is a direct correlation with decreased mobility and constipation. So when we start connecting these, I would probably draw an arrow from her hip repair to her constipation because I know those are connected. We could also say that her difficulty ambulating would be connected to this mobility or her hip surgery, right? Or that her decreased mobility is connected to the tissue integrity. So it's a way of kind of putting these things out here that are going on with your patient and trying to connect them and see how they're affecting all of the body systems. All right, that does it for our mini lecture. Sorry we ran out of time in class today, but thanks for watching this piece. If you have any questions, just let me know, and I'll see you next Monday in class.